Workshop and Symposium 2018. This prayer symposium is the part of the 5th jaknews, and this year the theme is Escalating Neurological Skill and Research Existences. And this is a great opportunity for us and such an honor to have an expert in neuro-ophthalmology and neuro-otology, Professor Michael Stroop. Welcome to Jakarta, Prof. And we are also delighted to have our colleagues from outside Jakarta. Let me say hello to Surabaya, Yogyakarta, Solo, and Palembang to join us in this pre-symposium webinar. And this pre-symposium webinar consists of lecture and discussion and also case presentation. So all of the attendees from Jakarta and outside Jakarta can ask the speakers for the topic today is vertigo and dizziness in clinical practice. And to guide this pre-symposium, I presented to the stage Dr. Ni Nengah Rida Aryarini and Dr. Diah Tunjung Sari as moderators. So for Dr. Ni Nengah Rida Aryarini and Dr. Diah Tunjung Sari, the time is yours.
Thank you, Dr. Yesi Astri, for your nice opening. Okay, good morning, all of you, my teachers, my colleague, and all of you, and thank you for your attending. And also, I would like to say thank you to participants outside the University of Indonesia. University of 11 Maret Solo, Gajah Mada University Yogyakarta, Sriwijaya University Palembang, and Airlangga University. It is a great opportunity for us, Neurology Department of Faculty of Medicine, University of Indonesia, especially Neuro-Ophthalmology and Neuro-Otology Division, to help this special session of this annual event, the 5th jaknews, Jakarta Neurology Exhibition, Workshop and Symposium 2018. First of all, I will introduce my member of Neuro-Ophthalmology and Neuro-Otology Division, the one who will sit beside me, Dr. Diah Tunjung Sari, neurologist, and another one, Dr. Freddy Sitorus, maybe a little bit late. And we will have this discussion about the vertigo and dizziness diagnosis and treatment. And I would like to say thank you to Prof. Michael Stroop. Thank you for your coming. And I will read briefly about his curriculum vitae. I think you have already know who Prof. Michael Stroop is, but the committee wants me to read it, so I will read it. Prof. Michael Stroop was graduated from as a resident in the Department of Neurology in 1988 and became a professor in 2003. He has a lot of research activities and publication, and the latest research activities was with the title of Various Animal Model to Evaluate the Mode of Action of Aminopyridine, acetyl dearylations beta-histine, and the latest grants achievement in 2017 as a visiting professorship at University of Manila, honorary member of Indian Society of Ophthalmology. His current position is professor in the Munich University of Germany. So, because the time is too limited, Prof. Stroop, the time is yours.
Selamat. Is it? Yeah. Oh, the sound is okay. Salam alaikum. Shukran. Okay. So it's a great pleasure and honor to be here today again. I think it's at least my 5th visit to your wonderful tropical country, and I always appreciate your kind hospitality. Today we are cover the whole field of vertigo and dizziness. That means first how to systematically take patient history, which is the key to the diagnosis. Second, how to examine the vestibular system, how to differentiate acute peripheral from acute central vertigo, which is really essential if you're working in the emergency unit. And then we are going to focus on the most frequent peripheral, central, and functional vestibular disorders. And for this session, I would also like to welcome colleagues from all the other centers. This is very efficient to have a transfer of such a presentation to various other areas in the country. At the beginning of my presentation, I would like to give you an update of what has happened over the last 2 years in the field, things which are clinically relevant for you. Then, to warm up, I will present you 6 cases as a quiz, and then we move on with the patient history, clinical examination, and specific vestibular disorders. So, some highlights on vertigo and dizziness. What has happened over the last 24 months? We are currently reclassifying all vestibular disorders, as you will see, and you can download the current diagnostic criteria from the Journal of Vestibular Research for free. So that's very easy for you to be done, and then you have an update on what is going on. And here are the already classified vestibular disorders. I will show you the link in a few moments. So we have reclassified vestibular migraine, Meniere's disease, BPPV, more recently vestibular paroxysmia, functional dizziness, and bilateral vestibulopathy, and more papers are going to come out. So this gets to the classification of the various headache forms, and it will make your life much easier. And here, for those who'd like to take a photograph, this is the link to the Journal of Vestibular Research. All articles are open access so that you can easily download them. Take a photograph, please. Another thing which recently came out was a statement on the use of so-called vestibular evoked myogenic potentials. They have been proposed for the diagnosis of a dysfunction of the utricle and the saccule. We had a close look at all the papers published in this area, and it turned out that the only real indication for the use of these vestibular evoked myogenic potentials is the superior canal dehiscence syndrome. But otherwise, these examinations are not really necessary. So in case that you see many patients, in case that you plan to do an investment, this is not necessary. Thirdly, most of you, I suppose, are familiar with the head impulse test, first described by Michael Halmagyi and Ian Kurthos. We were all a little bit skeptical how useful this bedside test is, and therefore we compared the bedside test with the so-called video head impulse test. And it turned out that the sensitivity of the bedside is only 66%, which is low. That means if you see a lot of patients with vertigo and dizziness in your hospital, in your center, in your practice, it makes sense to invest in a video head impulse. later. I think we have a problem with the battery here because it goes up and down. Not sure, but this is not ideal. Another thing which turned out to be clinically very useful are new classes to examine a patient for nystagmus. With all modesty, they are called Michael's classes because it was my idea, and they made it on the cover page of Neurology. I'll show them again. So these classes will allow you to properly diagnose peripheral vestibular spontaneous nystagmus and to discriminate peripheral from central nystagmus. Now, this is essential in patients with an acute vestibular syndrome. What are the news on specific peripheral, central, and functional vestibular disorders? I'd briefly like to summarize that as a kind of an introduction to what I'm going to present later on. So when it comes to BPPV, I do recommend the so-called Semon Plus maneuver, which is a modification of the Semon maneuver to treat patients with BPPV. When it comes to vestibular neuritis, the new term is acute unilateral peripheral vestibulopathy, because we cannot be sure that it's always an inflammation. And we could show in animal experiments that beta-histine in a high dosage is very effective in patients with acute unilateral peripheral vestibulopathy. Then Meniere's disease. The use of steroids has been proposed for many decades. A recent study showed that they are not effective. So no indication for steroids in Meniere's disease, as you will see later. Beta-histine is effective in Meniere's disease, but you need high concentration, which we also achieved in the future by using a nasal spray of beta-histine. That's the future. In the meantime, you can also use beta-histine in combination with a monoamine oxidase B inhibitor, namely siligeline. Low dosage of beta-histine, which are approved, plus siligeline as a long-term treatment. For BVP, this stands for bilateral vestibulopathy, we do have new diagnostic criteria, and if we have a look into the future, there will be a vestibular implant. The vestibular implant is analogous to the cochlear implant, and it will substitute the missing vestibular ocular reflex in a very nice way, as you will see. Another disease, which is analogous to trigeminal neuralgia with recurrent short attacks of vertigo, is vestibular paroxysmia, which we just reclassified, and we could show in a recently published trial that vestibular paroxysmia can be successfully treated by oxcarbazepine. So carbazepine, oxcarbazepine, but I would recommend for your clinical practice that you can use a drug which is much better tolerated, which is also a sodium channel blocker, and this is lacosamide. I don't know whether this is on the market here or not. Lacosamide, do you have it here? Lacosamide, Wim? Anyway, for the future, this is going to be a very well-tolerated disease. When we move over to central vestibular disorders, there's a clear overlap, which you will realize in your clinical practice too, between vestibular migraine and Meniere's disease. And even patients with definite vestibular migraine, they can have endolymphatic eye drops. So you should not be concerned if a patient presents to you who fulfills the criteria for both diseases, which is pathophysiological linked, since vestibular migraine also affects the inner ear. Then for episodic ataxia, we just have finished a trial showing that 4-aminopyridine and acetazolamide are both effective. And for cerebellar ataxias, I've found a new drug which is evidently very effective in various diseases leading to cerebellar ataxia. 1 minute. Okay, so now I will start the presentation to warm you up clinically with a quiz of 6 cases. So you can listen to the patient history. You will have 5 choices.
Recurrent attacks of spinning vertigo. How long will the attacks last?
Yes, between 1 second and 30 seconds.
How often do they occur per day?
Maximum 30 times a day.
That means how many attacks did you have over the last 6 months?
I guess about 1,000 attacks.
Do the attacks occur spontaneously or are they induced by anything?
They occur spontaneously.
What are the accompanying symptoms?
The symptoms are headache.
Nausea, vomiting?
No, nausea.
Okay, thank you very much.
You're welcome.
So you have 5 choices, as you can see. Is this a patient with migraine? Is this a patient with probable vestibular paroxysmia? Is this a patient with panic attacks, BPPV, or superior canal dehiscence syndrome? What is your guess? What? B, E, D. Okay, so in superior canal dehiscence syndrome and also in BPPV, the attacks are induced by certain factors, changing of head position or changing of pressure. But in this patient, the attacks occurred spontaneously, out of the blue. So this makes both diagnoses unlikely. Migraine, by definition, the attacks last at least 5 minutes. But in this patient, they lasted less than 1 minute. So the diagnosis is probable vestibular paroxysmia, characterized by recurrent short attacks of most often spinny vertigo, which occur spontaneously out of the blue, and they respond very well to Tegretol or oxcarbazepine or leprosamide. So now listen to the next patient and try to make the diagnosis.
What complaint has brought you to us today?
For dizziness, which I've had since early yesterday, ever since I got up.
What type of dizziness is it?
At first it was a spinning sensation, which has abated a bit. It was simultaneously combined with strong nausea.
Did you have any other complaints?
No, not until then.
What happened when you tried to focus on one point?
Then the image began to wander and again to wander. In other words, I was not able to focus on one point.
Besides dizziness, did you have any other complaints like seeing double, problem swallowing, difficulty speaking, paralysis or numb feeling around the mouth?
No, so far not.
And are you...
So, the leading symptom in this patient is acute onset of spinning vertigo, and also when he's fixating, the image is moving. The technical term is oscillopsia. Did any of you ever had oscillopsia? You will have it in a few moments. Everybody, please, also in the centers. Cover one eye, please, and now press rhythmically with the tip of the index finger on the lower eyelid of the other eye. What do you see? The image is moving. This is oscillopsia. Do you like that? If you do that for a longer time, you will feel nauseous. You will have visual vertigo, visual dizziness. And that's a very nice example to explain how vertigo and dizziness occur. It's a mismatch. So your visual system tells you, in such a situation, everything is moving. But your vestibular and somatosensory tell you everything is fine. And this mismatch leads to the feeling of dizziness and vertigo, and also causing nausea if you do it for a longer time. So this patient had acute onset of longer lasting spinning vertigo and oscillopsia. No other symptoms. What do we diagnose? A, B, C, D, We have to switch to the screen again. Nice to see the other colleagues in the center. So this was a typical case of vestibular neuritis. Acute onset of longer lasting spinning vertigo and no other accompanying symptoms. Did you get that? Okay. Now we switch over to the next case. You have 5 options: orthostatic dizziness, BPPV, superior canal dehiscence syndrome, Meniere's disease, and functional dizziness. Listen to the patient.
What complaint brought you to us today?
When I press on my ear, I have a slight attack of dizziness.
Pressing on the ear, slight attack of dizziness. Functional, psychogenic? No, what is it? The patient makes it very simple to you. Very easy. This is superior canal dehiscence syndrome. So changes of pressure, sneezing, coughing, pressing, lifting heavy weights, leading to attacks of vertigo. That's the symptom which many patients spontaneously report, but they're often misdiagnosed as this and this and that. Okay, so changes of pressure, inducing attacks of vertigo, superior canal dehiscence syndrome. This is due to a defect on top of the anterior canal. And then you get a pathological transmission of pressure to the semicircular canal. It was previously called perilymph fistula. Now listen to this patient. Again, you have 5 options. Functional dizziness. By the way, functional dizziness is the new term which cover everything which had been previously called psychogenic, somatoform, phobic, persistent perceived postural dizziness. So for your clinical practice, if you from now on use the term functional dizziness, you will have the umbrella for all the various subtypes, and you're always right. Because there's an ongoing discussion how to classify the subtypes, this classification and this discussion I think is useless. But just use the term functional dizziness, which is approved by the WHO. Functional dizziness from now on is one option. Bilateral vestibulopathy would be another differential diagnosis. In this case, vestibular migraine, vestibular epilepsy, and down.
Mrs. Suda, what are your major complaints?
Well, I'm permanently dizzy.
How is it in the early morning when you get up?
Well, in the early morning, I feel fine.
And when would symptoms begin? After you leave the bathroom or after breakfast?
After breakfast, especially when I leave the house, if I go shopping, if I have to queue.
That's very bad for you.
Yes.
Okay, thank you very much.
So in this patient, as many other patients with this disease, it's typical that they don't have any symptoms in the early morning, but after breakfast, then it starts. So this can be diabetes. This can be arterial hypertension, taking the medication. But what is your choice when it comes to vestibular disorders? It's worse leaving the house. It's worse in department stores. Functional dizziness. So one key feature which we elaborated is changes during daytime. And for functional dizziness, it's typical, not in all cases, to having less or no symptoms in the early morning. Next patient. So we have 5 choices: panic attacks, episodic ataxia, BPPV, vestibular drop attack, or too much shopping syndrome. So this video was taken by a CCTV in Istanbul. The patient came to Munich from Turkey and took that video with her. Then it was very easy to make the diagnosis. So she's the patient.
Yok şu anda değil. Şu an çantalara bakıyor. Aa düştü.
She's falling out of the field. We did not lose consciousness. So what do you diagnose? Syncope? No loss of consciousness and falling out of the blue? Too much shopping syndrome? When shopping shoes and handbags? So this is a vestibular drop attack. And you often see that in patients with Meniere's disease. But you have to ask the patient for that. Oh yes, I fall down. Yes, out of the blue. So keep in mind. Okay, last patient. The choices are normal, acute unilateral peripheral vestibulopathy, bilateral vestibulopathy, functional dizziness, or cerebellar hyperfunction of the vestibulo-ocular reflex. Here you see the patient, the view of the environment through the patient's eyes. He's walking, or she's walking. Is that normal? No. Okay. So if a patient tells you, when I'm walking, everything is moving up and down. When I stand still, everything is fine. When I like to read a sign or identify a face during walking, everything is moving. But then I have to stand still to read the sign. What is your guess? What's missing in this patient? The vestibulo-ocular reflex. How do you test the function of the vestibulo-ocular reflex? Which test do you use? Any ideas? Which test do you use? We will talk about it. We already talked about it. It's the head impulse test. And by the head impulse test, you can make the diagnosis in most patients, but not in all patients, to properly diagnose bilateral vestibulopathy. And here you see the finding in this patient. The head is quickly turned to the right and to the left. You see that the eyes move with the head, and then the patient makes a refixation saccade. So in some cases, it can be very easy to diagnose bilateral vestibulopathy on the basis of the patient history and doing the bedside head impulse test. So bilateral deficit of the VOR, and this is a typical case of bilateral vestibulopathy. So this was the warming up for you this morning. And I think now you are very much interested in the topic on how to properly diagnose vertigo and dizziness. And during the next 45 minutes, we will focus on these four aspects. First, how to systematically take the patient history, which is essential. That's the key to the diagnosis. Second, how to examine the vestibular system. Thirdly, how to discriminate between acute, peripheral, and central vertigo. And finally, I'm going to present you the most frequent vestibular disorders, peripheral, central, and also functional. And as you can see, we just have 4 basic questions. We have 4 tests and 5 clinical signs. So mathematically, it's a very simple problem to diagnose vertigo and dizziness in your clinical practice. And I know that these frequent symptoms do have not the best reputation. So doctors don't like patients who come and tell me, I'm dizzy now for 5 years. Ooh. Or in the emergency room, oh, I have an acute onset of severe spinning vertigo, lasting now for 6 hours. 65-year-old patient, arterial hypertension, diabetes, heavy smoker. Oh, is that a stroke in the brainstem? So these are the 2 scenarios, and at the end you will deal with these patients very easily. So, as I said, vertigo and dizziness are very frequent symptoms. How frequent? You can see from the interview results of the National Interview Service in the United States on 214 million Americans. And it turned out that in the previous 12 months, 11% of these Americans were suffering from dizziness. And I think since Donald Trump is president, the number will even go up and not down. Is anybody disagreeing on that? No Republicans here? Okay, I'm delighted to see that. Okay, in contrast to what is commonly believed, it turned out that it mainly affects people in the middle of their life. So these are not the patients at the age of 70 or 80, but most of the patients are in the middle of their life, between 40 and 60. Thirdly, if you compare the symptom of dizziness, it's not a disease, it's a symptom, with other frequent diseases, you will see that it is more frequent than diabetes mellitus, it's more frequent than cerebrovascular, cardiovascular diseases, and cancer. So it's really a relevant symptom. And finally, it's associated with a 1.7 times higher mortality. So you have to diagnose these patients. Why do they have a higher mortality? First, they can have central vertigo due to an ischemia of the brainstem and the cerebellum. And secondly, they have a higher frequency of falls. So, therefore, the higher mortality. What are the different vestibular syndromes and diseases? Here you see data from our dizziness unit on more than 30,000 patients who have been systematically examined and treated over the last years. So, number 1 and 2 equally frequent, functional dizziness and BPPV. Number 2, central vestibular syndromes arising from the brainstem and cerebellum. So central means really brainstem and cerebellum. That means if you do an MRI, look at the brainstem and cerebellum. Supratentorial structures are not relevant, although we have something like a vestibular cortex in the parieto-insular area. Then, the most frequent cause of recurrent spontaneous attacks of vertigo is vestibular migraine. Then we have here Meniere's disease, unilateral and bilateral vestibulopathy, and vestibular paroxysmia, which accounts for about 4% of all patients. So now we move on and have a look at the patient history. 4 basic questions. You can memorize them as a triple TA. What does T stand for? T stands for, when it comes to vertigo and dizziness, time. Time is essential, not only in stroke. What else? T for triggers. T stands for type. And A, analogous to headache, stands for accompanying symptoms. So triple TA. Time course. I will elaborate that in a few moments. Basically, patients can present in 3 ways. Those with attacks, those with an acute onset of longer-lasting symptoms, the so-called acute vestibular syndrome, and then we have patients who have persisting symptoms. Other aspects are the time, triggers, and accompanying symptoms. So here you see the most relevant issue, and this is the time course. As I said, 3 ways of presentation. First, those with attacks. If a patient has attacks, your next question will be, what's the minimum and the maximum of the duration? If it's less than 1 minute, you have 3 important differential diagnoses. First, BPPV, second, vestibular paroxysmia, and thirdly, which is very rare, superior canal dehiscence syndrome. If a patient presents with attacks which last many minutes to hours, just 2 important differential diagnoses. Vestibular migraine, 5 minutes to 72 hours, or Meniere's disease, 20 minutes to 12 hours. And the time scales, which you see here, they arise from the International Classification of Vestibular System. So we agreed on these time scales, which was not an easy process. Second scenario, patient with acute onset of longer-lasting symptoms. So this can be what was previously called vestibular neuritis, and which you should now call acute unilateral peripheral vestibulopathy, or it can be a brainstem and cerebellar infarction. This can be discriminated mainly by the clinical examination. And then we have patients, as I said, who have persisting symptoms for more than 3 months. This can be functional dizziness, this can be bilateral vestibulopathy, but this can also be a neurodegenerative disease affecting the cerebellum and or the extrapyramidal system. So simply on the basis of the time scale, as you can easily see, you can discriminate the most frequent types of vertigo and dizziness. That means for you, after you have taken the patient history, you should have a clear picture in your mind about the time course. The next thing, as I said, is the type. There are basically two types. First, those who have spinning vertigo. Spinning vertigo is the term which you should use from now on. Spinning vertigo means anatomically and physiological a dysfunction of a semicircular canal or fibers transmitting these information from the semicircular canals. Why? Because semicircular canals sense angular acceleration. If there's a deficit, you will get spinning vertigo and a nystagmus in the plane of the canal. On the other hand, you have patients with postural imbalance and dizziness. This is more ambiguous because it can be due to a sensory deficit, as in bilateral or unilateral vestibulopathy in a compensated state, or it can be due to neurodegenerative diseases, or it can be due to functional dizziness. So try to discriminate. I know it's difficult for the patient to say that. Another important factor are what induces the symptoms, or do they occur spontaneously? In Meniere's disease, in migraine, it occurs spontaneously. However, in BPPV, it's induced by changes of head or body position. In perilimb fistula, by changes of pressure. In functional dizziness, it also depends on many factors. Being in a department store, doing sports improves the symptoms, less symptoms in the early morning. And finally, number 4, we have accompanying symptoms. And they can be easily classified into 4 groups. First, those arising from the inner ear, as in Meniere's disease. Secondly, those typical of migraine. This also includes the question, do you suffer from migraine, or did you ever suffer from migraine? Because this is an important factor to properly diagnose vestibular migraine. Then we have serious accompanying symptoms, double vision, paresis or ataxia, and unspecific symptoms, nausea and vomiting. So, 4 aspects: time course, type, triggers, accompanying symptoms, and now you move on with the bedside examination. Do you know any tests for the vestibular system? Which tests? How can you examine the vestibular system? What do you have to look for? Any tests? Head impulse test, we mentioned. Anything else? Positioning maneuvers. Looking for a nystagmus. And the Romberg test. So here you see the summary of what is relevant when you have a look at the vestibular system. Just 4 tests. You don't need more. So, head impulse test, look for a nystagmus, do the positioning maneuvers in every patient, and the Romberg test. So, one thing you can start with is looking at the vestibular ocular reflex. What is the vestibular ocular reflex doing? It's generating compensatory eye movement during head movement and walking. That's the basic function. What's so special about the vestibular ocular reflex? Well, it's the latency. The latency, that means the time between the beginning of the head movement and the compensatory eye movements is only 8 milliseconds, which is quite unique. And this is because only 3 neurons are involved. You see how the VOR works here on the right side. When the head is turned to the right, for instance, there's an excitation. Try to remember that of the right horizontal canal. There's always excitation in the direction of the movement. That's also true for vertical canals. Moving the head downward, excitation of both anterior canals, for instance. Turning the head to the right, excitation of the right horizontal canal. And this generates eye movements with the same angular velocity in healthy subjects as the head movement. How the VOR works, you can literally see by a very simple test. Everybody please, also those in the other centers. Hold your arms like that, fixate the nail of your thumb, keep your head and trunk stable, and now move your arm with increasing angular velocity to the right and to the left. How is the image of the nail of your thumb? Sharp or blurred? If you blurred. Now do the opposite experiment. Keep the target stable and turn your head to the right and to the left with increasing frequency. How is it now? Crystal sharp, if your VOR works. If not, you will have the same blurred vision as in the first experiment. In the first experiment, you used your smooth pursuit system, which is fine. However, many neurons are involved, and therefore the latency is 80 milliseconds. In the second experiment, you used your VOR, the latency is only 8 milliseconds, 1/10 of that. And that's necessary for compensatory eye movements during running and walking. And here you see a few patients in whom the VOR was tested. And I briefly like to demonstrate the VOR. Take off your glasses, please. How to test the VOR. You can stand. Stand. So this is something you can do pairwise. So the patient has to fixate your nose. You hold the patient's head very tight as a rough test. Warn the patient. Make sure the cervical spine is passively movable. Fixate my nose, please, and then do one turn. One quick head turn, which should be unpredicted for the patient. And then you look whether the eyes stay on the target or not. Later on, you can do that pairwise. Thank you. And here you see some patients. And for the interpretation, it's very important, as I said before, that you know which side is activated during head movements. It's always the side to which the head is turned. You see in this patient, if the head is quickly turned to the right, the eyes stay not on the target, they move with the head. And then the patient has to make a refixation saccade, indicating a deficit of the vestibulo-ocular reflex on the right side. Here another patient. Quick turns to the right, the eyes move with the head to the right, and then the patient has to make a refixation saccade. So it's a VOR deficit on the right side. So these are the cases which are often shown during presentations. In clinical practice, however, it turned out to be a little bit more difficult. And an alternative way to really quantify the function of the vestibulo-ocular reflex is the video head impulse test. It's a very simple machine. I have 2 of these machines in my office, and I examine all my patients by myself. It takes a maximum of 2 minutes. Calibration, and then the video head impulse test. So here you see how it works. This machine measures the angular velocity of the head and the eyes, and you can see it here. So this is the head velocity and the eye velocity. And here you see an original recording in a healthy subject. So in red, the angular velocity of the head, and in blue, the angular velocity of the eyes. And in healthy subjects, it's identical. And at a time point of 60 milliseconds, the system measures the angular velocity of the eyes divided by the angular velocity of the head. And here you see another recording, this time from a patient. You see this is the fine angular velocity of the head and this of the eyes. And you see the maximum is only 50% of that, what is reached by the head velocity. So this patient has a severe deficit of the vestibulo-ocular reflex on the right side. Very simple method. The best way to understand it is doing it, learning by doing. And it's very simple and very reliable. And as I said before, we compared the bedside with the video head impulse test. The bedside is not that good, 66%. Okay, next scenario. How is that related to our topic? This is after lunch radiology conference. Okay, we all made this experience. So the term nystagmus comes from the Greek term nystatsein, which means falling asleep, getting drowsy. And this is accompanied by slow movement and a fast movement. Which one is the pathological, the slow movement or the fast movement when you fall asleep? Think a moment. The slow movement. And the same is true for the nystagmus. So the pathological phase is the slow movement, and the quick brings the eyes back to the target. For you to remember, when it comes to nystagmus, the fast component is always beating towards the more active labyrinth. AA, fast component, active labyrinth. Okay? Try to remember that for the rest of your life. We have various types of nystagmus. And when it comes to vertigo and dizziness, most patients with an acute vestibular syndrome do have a spontaneous nystagmus. Spontaneous means it occurs when the patient looks straight ahead. So very simple definition. And there are two subtypes of spontaneous nystagmus, either peripheral and central. How do you discriminate both? This can be done by such a simple device. Because the typical feature of, as you will see in a few moments, a peripheral vestibular spontaneous nystagmus is that it can be suppressed by visual fixation. Patient looks at you and you don't see a nystagmus. And then you put on such a device, and this device prevents visual fixation of the nystagmus. And then you see the nystagmus. So that discriminates between peripheral and central. Here you see an example in the lower part. So this patient is looking straight ahead and you don't see a nystagmus. If you put on the glasses, you will see the nystagmus. Okay? The fast phase speeds to the right or to the left? Right. Which labyrinth is more active? The right one. So he has an acute vestibular neuritis on the left side. And the typical feature is he can suppress the nystagmus by visual fixation. Okay, so here are the various types of central nystagmus. Important in particular for the neurologist. Number one by far is downbeat, then upbeat and central positioning nystagmus. The next thing, after you have tested the head impulse and after you have looked for a nystagmus, is doing the positioning maneuvers. Can you sit down there? And they shall be done in every patient, independent of the patient history. Okay, take off your glasses. So you put on the glasses, turn the patient's head in one direction, and then move the patient in the opposite direction. The turning of the head makes sense and is necessary because the vertical canals are tilted by 45 degrees from the frontal plane. So to align the right posterior canal in the plane of your movement, the head has to be turned by 45 degrees to the left and vice versa. So that's very important. That's the way it works. Thank you. And the final thing which you should do is the Romberg test. The Romberg test was already described in 1871 by Maurice Romberg, and it helps you to identify a sensory deficit. There's often confusion about what does the Romberg test tell you. Can you come to the podium again? Take off your glasses, please. Put them there. So there are 4 ways on how to examine the Romberg test. You stand. Okay, both legs apart. Open your eyes, close your eyes. Open your eyes. Number 2 is both legs together. Close your eyes, open your eyes. Now 1 foot in front of the other. Close your eyes. You see he sways a little bit more. Open your eyes. Now please stand on 1 leg. And close your eyes. 1, 2, 3, 4, 5. So if someone is able to stand on 1 leg with the eyes closed for at least 5 seconds, you can be sure that his or her balance is fine. So the question is, what does that tell you if the subject sways much more with the eyes closed? It tells you that there is a sensory deficit of the vestibular and or somatosensory system. This is what it tells you. Why? Easy to explain. Which are the channels that you use for a proper balance? Visual, vestibular, and somatosensory. If you close the eyes, what will be the channels remaining? Vestibular and somatosensory. So if someone sways much more with the eyes closed, there's a deficit either of the vestibular and or somatosensory system. How to examine the vestibular system? Head impulse test. How do you examine the somatosensory system by using your tuning fork. You put them here on the malleolus, and then you get an idea if the patient can feel it or not, and that will help you to discriminate the sensory deficits, whether it's vestibular or somatosensory. Okay, good. Now we have a problem with the projection, but that's a nice break for you to recharge your battery, to memorize everything. The time point was ideal because we now switch over to a new topic. Terima kasih. Shukran. Thank you for your attention. And sorry again for the technical issues. We prepared everything. It worked for 1 hour before the presentation, but then only half an hour during the presentation. Okay, sorry for that. Thank you. Now we have time for questions, please. Sama-sama. So first questions from here and then questions from the centers. Please, I'm listening. We need a microphone for questions. Do we have a microphone? There's a question. Please use the microphone and speak very loudly so that the other centers can also hear what you say.
For Meniere disease, the treatment with beta-histine, for how long will you give the beta-histine?
That's an important question. So similar to arterial hypertension, similar to diabetes, similar to epilepsy, Meniere's disease is a chronic, persisting, remitting disease. That means you need a long-term treatment. I have patients whom I have been treating now for more than 10 years with a daily dosage adjusted. The aim of the treatment that's analogous to epilepsy is free of attacks for at least 6 months. If a patient is free of attacks for 6 months, then I taper the dosage by 1 tablet every 3 months. But there are some patients who do not want a reduction of the dosage, so they keep 20 tablets taking for 10 years. They're happy with it. Hearing is stable, tinnitus is stable, they go back to normal life. So 6 months free of attacks, then you can go down. If a patient after 3 months of treatment is not better, you have to go up. And once again, 96 TRD or 48 plus 5 milligrams psilocybin.
How about the dizziness with pathology of the macula utriculi or saculi?
Okay, it's a question about otolith dizziness. Otolith dizziness is relevant in 2 situations. Most relevant after you have treated a patient with BPPV. The otoconia, as we could demonstrate, fall back to the utricle. Then you have more otoconia than before the treatment. And this leads to post-repositioning otolith dizziness, which lasts about 1 to 2 weeks. This is centrally compensated. This is something patients have to know beforehand. So I always tell the patient, if you do the maneuvers properly, then it's a good sign if you feel dizzy afterwards. This is important for the patients to know, otherwise they will not be happy. But if you can predict that, you sound like a prophet. You can tell the patient this will happen and this is a good sign. You can accelerate probably this central compensation by beta-histine. So we give beta-histine after successful maneuvers for 1 to 2 weeks, 96 3 times per day. And this theoretically accelerates central compensation. That's the only effect beta-histine has in BPPV. It does not have an impact on BPPV by itself, but only on central compensation of post-repositioning otolith dizziness. The second scenario is post-traumatic dizziness. That's also very frequent. Head trauma, dislodge of otoconia, and then the patients feel dizzy. So this is not cervicogenic dizziness after head trauma. This is otolith dizziness after head trauma. So 2 scenarios.
One more question. how many times will you give the sermon or liberative?
Okay, the question
maneuver?
about frequency of the sermon maneuver. Our general recommendation is first, show the patient how to do the maneuver. Second, check whether the patient is doing that properly or not. You have to convince yourself that everything is done in a proper way. Can you come to the podium again? Because there's one typical mistake. Take off your glasses, please. So, this is something, moving downward by yourself. Okay, patients often do properly. Keep that position for 1 minute. And now move in the opposite direction. Oh, he's a perfect volunteer. Because he's not doing what most patients spontaneously do. So they fall down and then they turn their head like that. Now it's not working. So the canal has always to be aligned in the plane of your movement. Okay? And I can fully understand the patient because nobody would like to fall down with the face down. Okay? So you have to make sure that the patient is doing that properly. Another mistake which often occurs is the patient is here, then goes up and makes a break. That's very bad. Okay, then I had one patient who did it that way. Very athletic, but not effective. Okay, so make sure that the patient is performing that correctly. If this is done, the success rate is close to 100%. Okay? Good questions, by the way.
How many times we will do
3 times in the morning, 3 times at noon, 3 times at night for 3 days. 27 maneuvers. 3 over 3. With a sermon plus, I think you need less maneuvers. But we haven't examined that systematically yet.
Okay.
We do a controlled study, sermon versus sermon plus. This is what we do. You have to use the microphone. No? Oh, that's a good question about the velocity, the angular velocity. We examined that with this mechanical model. It turned out to be very useful. So, velocities, to be specific, between 90 and 180 degrees per second will do the job. So, not too slow and not too fast. Okay? So, the way I showed you, this is the velocity which is appropriate. Yes, ma'am.
Yeah. Do you have experience to treatment a pregnant woman with Meniere disease? Is it
Okay,
we can apply the management?
It's a general question about pregnancy and medication. So, as a father of 4 children, I recommend no medication during pregnancy if possible.
So we just wait until the maybe hormonal?
Hormonal is of course with migraine. Migraine can be better or worse. MS can be better or worse during pregnancy and after pregnancy. So if possible, no medication during pregnancy. A healthy child is very important. Okay, further questions?
The most frequent of the six frequent.
The most what?
The most frequent of the 6
diseases?
Yeah, diseases.
So the most frequent one is BPPV. Number 2 is Meniere's disease.
Yes.
Number 3 is vestibular neuritis. Number 4 is bilateral vestibulopathy.
Yeah.
Number 5 is vestibular paroxysmia. And number 6 is superior canal dehiscence syndrome.
Okay.
So that's the frequency. Any questions from the centers? So we are all on board. The quality is perfect of the projection. A sharp view to the centers. Any questions from the centers? We have a sound.
I would like to ask about side effect for high dose beta-histine.
The question was about side effects of beta-histine. So the champion, it's a 72-year-old lady. She had been taking 80 tablets per day, every day, and she had no side effects. In other words, if a patient tolerates one tablet, he or she will also tolerate 10 or 20 or 30. Relevant side effects are sometimes fullness of the stomach and the gut, and in these patients I often give a proton pump inhibitor, pantoprazole. That often works. Rarely patients do have an allergy not to beta-histine, but to gluten and things like that. So these are the two situations. You should not give it in patients with bronchial asthma and in patients with an ulcer. But in general, my experience with, I think, about 1,000 patients is it's very well tolerated, and high dosages are as well tolerated as low dosages.
Thank you.
There's another question here from the gentleman.
Thank you. My question is, when we have a bilateral vestibulopathy, how about the dynamic visual acuity test? It is effective or not? Dynamic visual acuity test that you use.
Okay, the question was about bilateral vestibulopathy and dynamic visual acuity. Normally, if you read a text and you turn your head to the right, you should be still able to read the text. Quantitatively, this means if you measure visual acuity, it should not go down by more than 0.2 in healthy subjects. In patients with bilateral vestibulopathy, it goes further down. So you indirectly can diagnose bilateral vestibulopathy on the phone. I did that with a friend of mine from Cologne. He had to read an article, then he was shaking the head and he was not able to read it anymore. For clinical practice, it's not really necessary because it's secondary. So the primary test, and this is what we always like, is the head impulse test. So you should perform a primary test of the function and thereby you make the diagnosis. And that's the reason why it's not part of the diagnostic criteria. So it's written in the comment about that, but we did not include that.
And another question is, how we see the Romberg test actually? The swaying or the falling down or which?
Okay, come
one?
to the podium. Okay. I'll show it again.
Okay. We must off our shoe or we can use our shoe.
I'll show you. So there are 4 conditions on how you should do it. The first one is both legs wide apart. You don't have to do that. This was added by a stupid neurologist later, not by Romberg. Okay, then close your eyes. So now this is very stable. The next, we have 4 conditions. Number 2 is both legs together. Close your eyes. 1, it's fine. Okay. Open your eyes, please. And now put one foot in front of the other, heel to toe, and stand like that. And now close your eyes. 1, 2. Okay, that's fine. So if he had a bilateral vestibulopathy, he would sway much more now. And even worse it is if you stand on one leg. And close your eyes. 1, 2, 3, 4, 5. You see, he's able to stand on one leg with the eyes closed for 5 seconds, which is perfectly normal. Okay? If you have a sensory deficit of the vestibular and or somatosensory system, then you're not able to do that. So it's not a direct test. It tells you a sensory deficit. What I don't like in this context is ataxia. I'm an expert on cerebellar diseases. Has become much more interesting for me than many other areas. And ataxia should be really limited to the cerebellum. Ataxia is related to dysmetria, no precise movement, the accuracy is not precise. So you just say about body sway. We see body sway.
It's only body sway, not falling.
Body sway, not ataxia.
Okay, thank you.
Because we have to have a clear terminology on what we are talking about.
We can use our shoes or must take off our shoes?
Well, without the shoes you are better.
Okay.
So ideally you take off the shoes. But in clinical practice it's not necessary. Okay.
Another question. I read that there is if the proprioceptive of swaying like that is sometimes when we have a neck stiffness.
Okay, the question is about cervical vertigo.
Yeah, yes.
Clear statement. There's nothing like cervicogenic dizziness or vertigo. There's no need to diagnose that because I think it does not exist. We had a series of 100 patients. We looked for diagnosis in patients who came to us with a misdiagnosis of cervicogenic dizziness. They all had something different. So there's nothing like cervicogenic dizziness. Delete it from your list. The same is true like diagnosis as vertebrobasilar insufficiency. Either you have a basilar stenosis or not. If you have a basilar stenosis, call it basilar stenosis and not vertebrobasilar insufficiency. And another thing I don't like is multifactorial dizziness. That means the doctor has no clue about the diagnosis. You can have this and this and that and name it. So patient can have peripheral vestibular deficit and a severe neuropathy leading to postural imbalance. So be specific, yeah, and not multifactorial and things like that. That's not helpful.
Actually, I want to ask about if the patient have a like tension type headache or have a spasm in his or her neck, and then maybe right or wrong, there is the proprioceptive sensory motor is getting blocked because there is also proprioceptive in a verticocolic reflex. It's not involving the.
So the cervicocolic reflex is not relevant in healthy subjects. It contributes only 2%, so it's not relevant. So no cervicogenic dizziness. If a patient comes with this diagnosis, look for something else. In general, for your clinical practice, do not look into the files. When a patient comes to you for the first time, ask the patient, why do you come to us? What are your major complaints? Because what is written in the files is unfortunately most often wrong. And then you are moving into the wrong direction and you have to make a U-turn. The shorter the U-turn, the earlier you're at your target. Okay? So don't look into the files. Get your own impression about the patient, unbiased and straightforward. Ask the 4 questions, as I said before: time, course, type, triggers, accompanying symptoms. Do the basic 4 tests. Head impulse test, look for a nystagmus, positioning maneuvers, Romberg, and then you will make the diagnosis. You don't need that many machines. So if you invest into machines, video head impulse test and calorics and audiogram. So these 3 machines will do the job. It's not trivial, but it's simple. Okay, I think we have some cases prepared. Is that correct? Yes. Maybe we can move on with the cases.
I'm sorry, from Surabaya, I want to answer the question about what is the drug of choice for the central vertigo and what is the role of the rehabilitation vestibular for central vertigo.
Okay, the question was about the drug of choice for central vertigo. Before you treat central vertigo, you have to have a diagnosis. So central vertigo covers various diseases. So one is vestibular migraine. Attack can be treated with ibuprofen and a prophylactic treatment with beta blocker, topiramate or valproic acid. In children, magnesium. If you have patients with episodic ataxia, you don't have that here, you probably have it. The treatment of choice is foraminopyridine. If you have a patient with a stroke, it's IV thrombolysis or mechanical recanalization, and aspirin or atorvastatin, or apixaban and atorvastatin. The 2 double A's. That's a prophylactic treatment of stroke. If you have a patient with the Wallenberg syndrome and severe spinning vertigo, you can give beta-histine to reduce the symptoms and accelerate central compensation. If you have a patient with Parkinson's disease and central dizziness, you treat the Parkinson's disease. If it's a patient with normal pressure hydrocephalus and it's proven, patients need a shunting. So it's very specific, and I don't like the term, the general term, as a diagnosis, central vertigo, because this means you have no idea. So you have to have a specific, it's cerebellar, or it's extrapyramidal, or it's after a stroke, or it's migraine, or it's episodic ataxia. So central vertigo as a diagnosis means nothing. Be specific. We don't have any drug which covers everything. Specific. Not because I think we should make medicine on a higher evidence-based level. Okay, now we move on with the cases. If there are no questions, please.
Okay, this is the first case. This is a 54-year-old male with consulted for evaluation of vertigo. So 11 days ago, the patient felt spinning sensation abruptly when he woke up in the morning. The symptom occurred continuously and worsened with head motion, but not with position changing. The symptom was accompanied by with nausea but not vomiting, and there wasn't neither hearing loss, tinnitus, headache, or fever. There wasn't any neurological deficit. The day after, patients were presented to the emergency department. This patient had previous stroke twice, 2 and 6 years ago, with residual symptom. There was left-sided hemiparesis. This patient also has hypertension and diabetes mellitus. The medication, now the patient had amlodipine, metformin, ASA, clopidogrel, and folic acid. This is from the clinical examination. From the blood pressure, the systolic blood pressure was 160, and the diastolic blood pressure was 90. The pulse was 84, the respiratory rate 16, and the temperature was 36.7. And there was also normal general examination. This is from the neurological status. The patient was alert. The GCS was 15. The pupil was equal. Around normal light reflex was normal. There's no cranial nerve palsy. From the motoric examination, there was left-sided hemiparesis without Babinski sign. And then there is no hypostasia. From the examination, the saccade and smooth pursuit movement were normal. Okay, this is the balance examination. From Romberg and Sharper-Romberg cannot be performed because the patient was with the left-sided hemiparesis. From the head shaking test, there was no nystagmus. Sorry. Can you please back to the case? From the examination, we found the fast phase alternating nystagmus. From the head impulse test, there was no negative, and from the skew deviation, the refixation was positive.
What do you mean by fast phase alternating nystagmus? What do you mean by that?
Bidirectional.
What?
Bidirectional nystagmus.
That means a gaze-evoked nystagmus.
Yes.
So when he was looking to the right, the fast phase was beating to the right. When he was looking to the left, the fast phase was beating to the left. So, and the head impulse test was normal, and he had a skew deviation.
Yes.
One eye above the other.
Yes.
Okay, good. In general, what I recommend for your future, all of you, if presenting a case, it should be, we found the following pathological findings. Focus on what is pathological. Assuming that you did a full examination, everything else, you did not find anything, because that makes everything much more condensed and much more reasonable. I think most of us, we are quite fast thinkers. So we have the following pathological findings, A, B, C, D, that's it. It's not relevant if the blood pressure is like that, the glucose is like that, and the urea is like that. So this is not useful. So the following pathological findings, 1, 2, 3, 4, focusing, okay? The same is in our hospital. So if a resident presents a case to me, I don't want to hear what's normal. I want to hear what's pathological, okay? And if I have specific questions, I will ask the questions.
That makes our life much easier. The same is true for the medical students. Following pathological findings, 1, 2, 3, 4. The leading symptom of the patient history was this, and that were the accompanying symptoms. That's it. So in 3 minutes you get an idea. Focused, condensed, straightforward. Okay, please move on.
Okay. The next case.
So, is that the case?
Yes, this is the case, sir.
Okay, so what is your diagnosis with these clinical findings? Is it peripheral or central? Central. What are the arguments for central? The patient history with the risk factors. And what else during the examination? The skew deviation. The skew deviation is definitely central. So the best test for skew deviation is the alternating cover test. Then you see how the eyes are moving. If you see that, as I said, it's central. But only 30% of patients with a brainstem infarction do have skew deviation. Another thing is the gaze-evoked nystagmus. So when he looks to the right, the eyes are beating to the right. When he looks to the left, the eyes are beating to the left. In this case, however, one can never say whether this was already there, because many subjects had a minor stroke in the brainstem or cerebellum and do have a gaze-evoked nystagmus, which was already there before the acute phase. So the much stronger argument was a skew deviation, because this goes away after 1, 2, 3, 4 weeks. So this is evidence for an acute lesion. What's strange is that the patient did not have a spontaneous nystagmus with his history. As I heard the history first, getting up in the morning, having the first attack of vertigo, what would your guess be? BPPV. Why does it occur in the early morning? Typically. Very easy to explain. Because overnight, the crystals form a clot. And we could show in the mechanical model that the impact of the clot on the endolymphatic flow is much higher than single crystals. So that's the explanation why most patients have the first symptoms getting up in the early morning, turning around in bed, and then having an attack of vertigo, which can also be accompanied by otolith dizziness, postural imbalance when they would like to go to the bathroom. Okay, how did you treat the patient? He got already everything he needed. So he had clopidogrel aspirin and atorvastatin. Okay. No, I would not give that. Okay, second case. Oh, I mentioned some. Can you go back? I saw. The Fukuda test is not necessary. It's not helpful. It's more confusing than helpful. Therefore, I said 4 tests. Fukuda, what does it tell you? If a patient has a peripheral deficit on the right side, most of the patients turn to the right. But this is indirect. Some patients overcompensate and move to the left. So it ends up often with confusing results. Which test do we have for the vestibular system? Head impulse test and video head impulse test. So the primary test is this what we need. Okay, not the secondary consequences, which are often compensated or overcompensated, leading to unnecessary confusion with the doctors. Focus on the crystals. Okay, good, move on. So that's the second case.
Okay, I'm sorry, Prof. This is, I think this case, why I bring this case to this conference, because in our country, the clinical practice for perform head impulse test and nystagmus is not so common, maybe not like in your country. In traditional teaching, we learned that we can establish the diagnosis of central vertigo from only a neurological deficit. So if in this patient don't have neurological deficit, so it's commonly misdiagnosed as a peripheral vertigo. And today we want to familiarize with this examination, the head impulse test and nystagmus, because in our country maybe is not very familiar with this examination.
Okay, the question is, I skipped that in my presentation because we have these technical problems. How do you diagnose central vertigo in an acute vestibular syndrome? You look at 5 clinical signs. Can you come to the booth? Come down. You're my patient. Okay, 5 clinical signs, the big 5. The first thing is you look for a skew deviation, a vertical divergence. This is personally the first thing I do in a patient with an acute vestibular syndrome. There's a very simple test. Okay, patient fixates the examiner's nose. You cover one eye and then you cover the other eye. This is the alternating cover test, which is most sensitive for a skew deviation. The next thing you look at is which type of nystagmus. Is it peripheral or central? The key feature of a peripheral vestibular spontaneous nystagmus is that it can be suppressed by visual fixation. So patient fixates, then you put on the glasses. Oh, now it's there. This would be a typical peripheral vestibular nystagmus, whereas a central fixation nystagmus is there although the patient is fixating, because by fixation the patient would like to suppress the nystagmus, is not able to do so because the patient has a central problem. The next thing I do is to look at a gaze-evoked nystagmus. So you go here. She has a transient physiological gaze-evoked nystagmus. You go there. And when it comes to a patient with acute vestibular syndrome, and let's say she has a spontaneous nystagmus to the left, then you look to the right, and then you see, oh, now it's beating to the right. Direction changing nystagmus. That's the key. Okay? Then the next thing is you do an examination of smooth pursuit. If it's smooth or saccadic, this is a weak sign because it's often difficult to cite. You have the spontaneous nystagmus and the smooth pursuit. And the final test is the head impulse test. The patient looks at the examiner's nose. You make sure the cervical spine is passively movable, and then you make one turn and another turn. With a smile, it would even be better. Okay, so if a patient has acute vertigo and a nystagmus and a normal head impulse test, this is central. So the key sample signs are skew deviation, gaze-evoked nystagmus, saccadic smooth pursuit, a central fixation nystagmus, and a normal head impulse test. Okay? Terima kasih. Good. Okay. Yeah. More comments? Questions?
Okay, maybe anyone has a comment or question?
Okay, move on to the next case.
Okay. From Yogyakarta. Oh yeah, I will from Yogyakarta. Want to ask you about the effectivity of electronystagmography and video nystagmography to differ the central vertigo and peripheral vertigo.
Okay, the question was about electronystagmography and video oculography. Nowadays, everybody is performing the video oculography. And the video oculography is relevant in 2 ways. First, for the head impulse test, and second, for the caloric irrigation. What we rarely do, and which is often not necessary, is to record smooth pursuit, gaze holding function, and saccades with the video oculography. So, for your clinical practice, it's absolutely sufficient to do the calorics and the head impulse test with the video oculography.
Okay, thank you for your answer. And from Solo, want to ask you about how to diagnose the superior canal dehiscence syndrome and what is the drug of choice for this.
Superior canal dehiscence syndrome. The leading symptom, recurrent attacks of vertigo, as I said before, induced by changes of pressure. What patients also often have is a so-called autophonia. They can hear the voices of their own body or their speech much louder in the affected ear. So I had one patient who spent 6 weeks in psychiatry because he reported he can hear his eye movements in his left ear. So these were no hallucinations, but this was autophonia. Another thing which is quite impressive in these patients, if you test for the vibration sense, the patients can hear that in the affected ear. So it's transmitted via the bone to the temporal bone, and they can hear it. Oh, I hear your tuning fork in my right ear. The tests for the eye movements and induced changes of pressure are pressing against the closed nostrils, pressing into the stomach, and pressing the tragus, and to look for a nystagmus, ideally using Frenzel's or Michael's glasses. The next thing is you can do a CT of the temporal bone, high-resolution CT of the temporal bone. The problem with that is that 2% of us do have a very thin bone on top of the anterior canal. So some patients are misdiagnosed as superior canal dehiscence syndrome, having something else, but showing a pathological finding on the CT scan. So I would be skeptical with the CT scan. Treatment? Well, my recommendation is make the diagnosis, explain the mechanism to the patient, and avoid changes of pressure. Of course, some patients are treated by surgery, most often a plugging of the canal, but this requires very experienced, skillful surgeons who have done that many times in their life. Otherwise, you just destroy the labyrinth, which is not helpful. Okay, further questions from the centers?
No other question?
No, so we move on to the next case.
Okay. Slide. Okay, this is the second case, 53-year-old male. 2 months ago, the patient felt spinning sensation, also abruptly in the morning, but she forgot what she was doing at that time. The symptoms were bothersome and worsened with any movement, and the patient felt better when she was lying down. The symptom was accompanied with nausea and vomiting, and there wasn't neither hearing loss or tinnitus. There wasn't any neurological deficit also. A week before, the patient reports that she got flu-like symptoms. The spinning sensation continued about a month, and afterward, patient felt dizziness, like floating sensation. There's no significant medical history before the previous one. The vital signs were normal, and there's also normal general examination. This is the neuroautological examination. The Romberg and Sharpen Romberg, there's no deviation. The pass pointing and finger to nose normal. Shaking test, no nystagmus. From the gaze evoke nystagmus, there's also no nystagmus. From the head impulse test, there was saccadic, positive saccadic. The skew deviation were negative. It's negative. Okay. That's it, sir.
Any comments on this case from the audience? Any ideas? How long did the initial symptoms last? Several days or weeks?
For a month. About a month.
Continuously?
Yes.
Every morning?
No, continuously. For the first time, the sensation was felt in the morning.
Okay, any ideas? There are some differential diagnoses we can discuss. What can it be, generally spoken? Getting up in the morning, having a first attack of spinning vertigo. BPPV would my first guess. Frequent diseases are frequent. Okay, then the key question is, how did you feel when you sit down? Did you still have spinning vertigo? Patients with BPPV normally do not have any symptoms under static conditions. Whereas patients who have a vestibular neuritis, they have continuous spinning vertigo even while sitting down. It worsens with movement, so the question is, did you feel spinning vertigo although you were sitting down? No, after 1 minute it went away. No, it continued permanently. So this is the key question from the patient history to discriminate BPPV from a probable vestibular neuritis she might have had in these days. But she fully recovered, did she?
After 1 month, yes.
Yes. Okay, the Fukuda test, I'm not happy with it, as I said before, because it often causes more confusion than it's helpful. So ideally, a patient with such a history goes to the doctor, GP, neurologist, ENT, whatsoever, when the symptoms begin. So in the acute phase, you have a good chance to make the diagnosis. Post hoc, after 1 or 2 months, it's often difficult. It has no therapeutic consequences, most likely. Secondly, you say to the patient, if this reoccurs, please immediately come to the hospital, that you are examined in the acute phase. And then you can make a proper diagnosis. So now it remains ambiguous. It can be BPPV. It could be a mild vestibular neuritis. These are the two, my favorite two diagnoses.
Yes, Prof. One of the limitations in our center, because many of patients come to our clinic for maybe for a month or 2 months, and so the signs and symptoms will be severe.
That's good for the patients, then they're cured, they recovered. So it has no therapeutic consequences. So, but it's good for you, for the consultation, as I said before, to tell the patient, if you have acute symptoms, please come to the hospital, because then it's much easier for the doctor to make a diagnosis. If nothing else reoccurred, there's no sense. So I'm very pragmatic, and I see most diseases from the point of view of treatment. Does it have any therapeutic implications? 2 Meniere's attacks in 2 years. 2 attacks of vestibular migraine in 2 years. No therapeutic implications. We treat if patients have 2 or more attacks per month. That's it.
Okay, thank you. I've already has 2 cases and no more cases.
Okay. Any questions or comments from the auditorium? We are totally on time. 2 minutes time for the questions. It's 13 minutes past 12. We need the microphone, sir. There it is.
Thank you. Now, they call by test. We still do the head-shaking test. What's your comment about this for teaching material?
I think the advantage of, and this is also recommended in the diagnostic criteria of the diagnostic Sermon maneuver, is that you can simply move on with the treatment. So it's one maneuver. You put the patient in the position, you see the nystagmus, and you treat the patient. So 2 in 1, which is ideal. Okay? And therefore, keep it simple, straightforward. Next patient comes in 2 minutes. Yeah? So you can see 15 patients with vertigo during 1 morning session. Yeah? By the way, you should like your patients with vertigo and dizziness. You should change your attitude. You should attract patients with vertigo and dizziness. You can learn from each new patient, as we also do. The history is always a little bit different, or there's a combination of things. Patient had vestibular neuritis, and then post-infectious BPPV. Patient comes back after 3 weeks after vestibular neuritis. No, I feel worse. Yeah, what's that? He can have post-infectious BPPV as 15% of the patients, or he can have secondary functional dizziness. So attract your patients, and the patients will like you, they will love you, if you can properly diagnose and treat them. And they will tell their friends and relatives, so that you attract more and more patients, and the more you see, the better you become. Learning by doing. Yeah? And vertigo and dizziness, as I said before, it's not trivial, but it's simple. In 95%. So don't be afraid of your patients. Oh yeah, dizziness, I like it. I'm listening to you for the first time. Most patients present you the diagnosis on a silver plate. Nowadays even more, because they go into the internet, they look for the criteria. Oh, I have functional dizziness. My doctor said I had vestibular neuritis. I don't think so. Yeah? And you can confirm what the patient tells you. I think that's a final ending. Positive statement. We have 30 seconds.
Excuse me, sir. Can I
to say thank you? So,
can I ask?
Sama-sama.
Thank you very much.
Mabuhay in Arab. Mabuhay, inshallah. Okay. That's it? Okay, I think we managed the technical problems. I hope you have enjoyed the session and enjoy the rest of the weekend. I'm flying back now to Singapore, Frankfurt, and Munich. Back to the office tomorrow morning. Goodbye.
Okay, I would say thank you to Dr. Ninengah Rida Ariarini and Dr. Dia Tunjung Sari as moderators, and also Prof. Michael Straub as our speaker today. As the case presentation and discussion ends, we came to the end of this pre-symposium webinar. As the master ceremony, I would like to say thank you to all the attendees for your attention, and also from outside Jakarta, Surabaya, Jogja, Solo, and Palembang, and I'm so sorry for the technical problems. And good afternoon for you, for all the attenders. Wassalamualaikum warahmatullahi wabarakatuh.